It is now my pleasure to welcome to the stage the Chair of AMGA's Board of Directors, Dr. Howard Graman, CEO of Peace Health Medical Group. Howard?
Thank you very much, Don. It's really a pleasure to be here to represent our Board of Directors, and I want to add my warm welcome to all of you. I'm sure you're in for a great couple of days of networking and learning. I know every year that I come here, I learn new things that I can take back to my organization. There's lots of great things about being on the board of AMGA. You get to help set the direction of this great organization. You get to hang out with the other board members who are some of the smartest people in our profession, in my experience. But perhaps one of the highlights is the opportunity to give this short address to everyone who comes to the meeting. Because it's such an important event, it takes a lot of time and thought to come up with what the subject might be. So I've given it that time, and I've made two assumptions, the first of which I'd like to check out before we go on. It's always good to take the temperature of your audience and see if we're all on the same page. And so the first assumption I made was that most of us here are interested in providing high-quality care to our patients. And so I just want to check that out. If you're not interested in high-quality care, could you just raise your hand for a second? A couple of sheepish people in the back of the audience there. It's okay, we're very inclusive, you're welcome as well. The second assumption I made is that you're probably here and you probably belong to the organization you do because you believe, as I do, that medical groups, integrated healthcare delivery systems, and other organized systems of care are probably the best vehicle through which we can achieve the triple aim in medicine, and that is to improve the quality of care of our patients, to improve the community health, and to do it at the lowest possible cost. And that's why I've decided to choose a topic that I have a fair amount of passion for, and it's this topic. Something that is really not a new idea. It was first popularized over 30 years ago by Dr. Deming. This whole idea of uncontrolled variation, and in terms of medical care, it really speaks to our inability, or probably more insidiously, our unwillingness to give consistently good care, even when we know the right way to do it. And if it was just a question of poor quality that was the result of this, it would be bad enough. But I would suggest to you that we also spend untold millions of dollars and squander our resources in the course of this unwillingness to provide consistent care. And we also put our patients' lives at risk when we do that. I think this has been considered a lot to be sort of background noise that is just necessary, but I believe we can do more, and I think it's the folks in this room. This is one of the most prestigious gatherings of healthcare leaders that ever occurs in our country. I think it's us here that we're the people that can fix this, and I'd like to address that today. I'm going to give you some examples from the literature about how we know that this is true, but before we do that, I want to give you a short personal story that I think makes the point quite nicely. A couple of years ago, I had this great opportunity to get together with some of my buddies from my teenage years. I helped organize a reunion of 8 of us who were inseparable from the ages of about 12 to 18. Many of you have groups of friends like that as well. And I just want to say as an aside, if you haven't done this, I'd suggest you do it. This is, as they used to say in Virginia, this is a hoot. We had 3 days of laughing and reminiscing. There are guys there who I hadn't seen in 40 years. On the second day of this meeting, one of my good friends, Mike, came over and said, "Hey, Howie, I want to show you something." When I was 15, I was Howie, and to some people, it doesn't change. So he brought me over to the corner. He said, "Howie, take a look at this." And he did the classic collar pull down. And many of you physicians in the audience know what I mean. It's less dramatic than the trouser drop or the shirt yank, but this was the collar pull down. He said, "Look at this." So he showed me right over his clavicle here, there's like his collarbone, there's like a 1-inch scar. So I said, "Mike, what's that? What's that about?" He said, "Boy, I got quite a story." He said, "A couple of months ago, I realized I hadn't been to a doctor in years, and I thought I should get a checkup. I was feeling fine, I wasn't worried, but I just thought, it's time." So I went to my doctor, and he did the usual thing. He talked to me, and he examined me, ordered some blood tests. Then he said, "Hey, Mike, when's the last time you had a chest x-ray?" Mike scratched his head, and he said, "Doc, I don't remember. It's been years. I can't tell you." He said, "Let's get a chest x-ray. Let's be complete. We'll get a chest x-ray too." So we did. And it came time to review the results. He said, everything looks good, your physical's good, your blood work's okay. But I got to tell you, there's a little something on your chest x-ray that's not quite right, and we're not sure what it is. It's a little spot. It's right over here, sort of in the center of your chest between your lung and your heart. And I spoke to the radiologist about it, and they thought it would be a good idea if we did a CAT scan to check that out further, because we don't fully understand what it is. And Mike said, hey, you're the doctor, go ahead, do what you need to do. So, of course, the CAT scan was done, and they came back for the results, and he said, Mike, we didn't get the answer. There's still a shadow there. I spoke to one of our pulmonary guys, and he said, if I was you, I would do a mediastinoscopy, which is a procedure where you go down through above the clavicle under general anesthesia, and we can sample that and make sure it's okay. It's nothing to worry about. And Mike said, well, now you got me worried. Let's go. Let's get it done. So he had the procedure, and he described it. He said, they put me under anesthesia. I asked him how it went. He said, well, to tell you the truth, it was a little tricky. They kind of nicked the lining of the lung as they went down there. So for a few days afterwards, I had some trouble breathing, a little chest pain. I got over that. My voice was a little hoarse because the tube they put down my throat caused a little irritation, but that got better after about a week. But he said, I got great news for you. I'm fine. The biopsy was normal. And this is one of those moments where you have to gather your strength, because I had a very strong reaction to the story. And it's the kind of strength you gather when one of your children calls you and tells you they cracked up your car, and you have to remember to ask them how they are first before you want to know what the damage was, right? You remember that? So I said a few empathic things. I said, Mike, I'm really glad you're okay, and I'm sorry you had to go through all that. And then I couldn't help myself. I said, Mike, you never should have had that chest x-ray. And that's the key. He was aghast. He said, what do you mean? Wasn't he being more complete? Isn't more medicine better medicine? And the answer is no. And often more medicine is worse medicine. We've known for 50 years. When I graduated medical school in 1973, I was already told that there's no value to a screening chest x-ray. It does nothing except irradiate the body. If you work in a coal mine or you smoke cigarettes, it doesn't tell you you have cancer in time to make a difference, so it's a wasted test. It took years for us to stop doing chest x-rays. It only was maybe 20 years ago when we stopped doing preoperative chest x-rays routinely. So this is the problem. We know things are not appropriate. We have evidence that they're not to be done, and we continue to do them. And we waste millions of dollars a year, and we put our patients in harm's way. I'm going to give you a few other examples from the literature about this, because I really think it's an important point to make. So let's go to the next slide. How about low back pain? We've known for 30 years, probably longer, but we started publicizing in 30 years ago, that if you have sort of straightforward central low back pain that doesn't radiate to your legs and there's no objective findings or a neurologic exam, that you're likely to get better no matter what is done within 6 or 8 weeks. You can go to physical therapy, you can put yourself in a rack and stretch yourself, you can continue normal activity, you can go to a physical therapist, you're going to get better. And that there's no value in doing a imaging of any kind for that kind of a problem until it's persisted longer or something else happens. Yet, a study that was done just recently, looking at how back pain is being treated, there was a disturbing trend that doctors and other providers were not following well-understood guidelines about this. And the most disturbing one was that in this 11-year period, there was a 57% increase in the amount of advanced imaging done for people with routine low back pain that wasn't going to get them into trouble and really didn't need to be done. Now, it would be bad enough if we spent all that money, but we also CAT scans, as many of you know, provide hundreds of times the radiation of a chest x-ray. And there's fairly good evidence that lots of radiation can cause trouble down the line, especially in children, but in adults as well. Let's go to another example. How about pap smears? When pap smears came out initially, we were testing a large population, and when you do that, you get the prevalence of an illness. And we found lots of cervical cancer, and it was a terrific screening test. It still is. But after you sample the population, and you know what the prevalence is, you begin to pick up the incidence of the disease, which is much less common. And after a while of the routine of doing yearly pap smears, the smart people in this field figured out, we've got most of it done, and it's a very slow-growing problem. We can easily go to every 3-year routine, and we'll still do the same preventive work. So people began providing guidelines to lessen the frequency of pap smears and to actually stop doing them if you've had hysterectomy because your cervix isn't there anymore. And after you reach a certain age, if you've been screened and you've been fine because the likelihood of getting it is virtually zero. So these guidelines have come out. Yet in our society, there's lots of doctors and lots of patients who are conspiring to do yearly pap smears. And in this study that was done recently comparing the United States and the Netherlands, and by the way, the Netherlands is one of those countries where the doctors actually follow the guidelines because they're instructed to do so by the government, and they tend to do a good job of that. They don't vary from it because there's a sense that the money they're spending is important. It could be used somewhere else. They don't have 18% of their GDP going to healthcare. And what they found in the study was that we spend 3 to 4 times the amount of money on pap smears, yet we have the exact same mortality from cervical cancer as they do in the Netherlands. Another example of excess use of our care. All good things to do, but none too much. How about colon cancer screening? We understand about colon cancer that you get it when you're around 50 unless you have a specific risk factor, and if it's normal, you keep getting it about every 10 years thereafter. But in this study that was done on Medicare patients, it was found that 38% of the time, Medicare patients were getting their colon screening more often than prescribed. They were getting it every 3, 5, or 7 years, even though they had a normal one initially. And they were also getting it well past the years that it was recommended to be screening. Colonoscopy is not a procedure without risk. We're putting elderly people who have other medical problems at risk when we do an unnecessary procedure. Here's another one, knee arthroscopy for osteoarthritis. In the last 12 years, there have been 3 separate studies, all in that throwaway rag journal we call the New England Journal of Medicine, that have said the same thing. Here's the first one in 2002, which was done in this country, where it's described how if you do a knee arthroscopy and clean things up a little bit for chronic arthritic pain, it's no better than if you do a sham operation where you fake the operation and don't actually do anything. People do exactly the same. A study done in 2008 in Canada showed that if you do surgery versus just sending people to physical therapy, the results are no different. And most recently, just a few months ago, the Finnish group showed once again that sham surgery and osteoarthritic knee arthroscopy, no difference. Yet in this country, we do 700,000 cases of knee arthroscopy procedures for osteoarthritis and meniscus tears. Now, the data here is a little bit hard to pick out because there are certainly some acute meniscus surgeries that need to be done because people are in trouble, they're in acute pain, has to be fixed. But a lot of arthritic surgery is there's a small tear, people are in pain, and you really can't tell whether that's going to make a difference because it might have been there for years, but they're fixed anyway at great cost. Again, a procedure done by definition in older folks that's not without risk. I can go on for a long time. I'm just going to give you 2 more examples. This one is CAT scans in the emergency department. This is a pet one for me. Not a PET scan, a CAT scan one for me. There's a group of really smart people got together and decided that there's a algorithm to decide who is at risk for getting a CT angiogram in the emergency room for a problem called pulmonary embolism, which is a blood clot in the lung, a potentially very serious and life-threatening problem. So they went through a lot of trouble to figure out how you narrow down the number of people who get the study. Because remember, a CT angiogram is a high-dose radiation test, and it should be done for those people who it's likely to be helpful in the diagnosis. So what this study did was they promulgated their algorithm, they put it in front of the doctors that work in emergency rooms in a number of hospitals, and then they went back a year later and reviewed 3,500 CT angiograms that were done in the emergency room. And a startling 55% of them were ordered on people who did not fit the criteria to have it done. This is a startling statistic. And it would be, again, bad enough if we just exposed them to radiation and created all that cost. But when you do a test on a group of people who have a very low risk of having the problem, there's always going to be a small amount of what we call false positives, which means you're going to make a diagnosis that's incorrect in a proportion of people. And this is not without risk because a person who's told they have a pulmonary embolism is put on anticoagulant medication, blood thinners, and it changes their life for years. And so there's a risk that we make this diagnosis on people who don't have the condition. Here's my final example, preoperative stress testing. Both the American College of Cardiology and the American Heart Association have both said that if you're not doing a cardiac or vascular procedure, there's only a narrow group of people who should have a preoperative stress test. And they've delineated who those are. But in this study done on Medicare patients, just taking a 5% sampling of the Medicare patients, it was seen that 2,800 patients were getting preoperative stress tests unnecessarily. It didn't fit those well-recognized standard guidelines. If you extrapolate that to the entire population of Medicare, there are 56,000 preoperative stress tests done this year without any basis. So I'm going to stop there, and I would like to paraphrase one of Tom Hanks' great moments in that movie Apollo 13 and say, Dallas, we have a problem. And I'm sure some of you have given thought to this as well, but I'd like to suggest several things that I think that this is, I think, largely, this is a stubborn problem, and I think it's our problem to solve. And here's a couple of thoughts that I have. This is not geared to be a question and answer period, although I'd love to do that, but I hope maybe it'll provoke some thoughts for the rest of you for the rest of the weekend and after that. My first thought about it is this. We need to do more education and less appeasement of our patients. This is just a fact that we can't avoid. I have a lot of people who say, it's just easier to order the test than to try to talk somebody out of it. I was a primary care internal medicine physician, 35 years. I made my living telling people they couldn't have antibiotics for an upper respiratory infection. And I did it effectively. I had such a good rap for that I had people thanking me for not giving them antibiotics when I was finished. And there are other people who say, well, if I don't order it, the guy down the street's going to order it. So I might as well do it. In this room, in this organization, we represent 435 medical groups and integrated delivery systems, 150,000 doctors, and we treat 122 million patients. And so the guy who's down the street is probably sitting in this room. And my suggestion is that we all just do it the right way and not use that as an excuse anymore. Second one, let's treat the illness and not the setting. I had a colleague of mine who's a family physician in Virginia when I was working at the Curlian Clinic, who used to moonlight occasionally in the emergency room. He said, Howard, what I find is really strange is that if a mother brings a child in to see me who's got a really bad earache and has got a fever, I do a quick history and exam. If I see a really bulging eardrum that's red, it's got some pus behind it, I give them a prescription for amoxicillin and they go home. So when I'm in the emergency room, that same patient brought in by that same parent with the same exact complaints is likely to get a CBC, a chest x-ray, a blood culture, and then a prescription for amoxicillin. We have to stop treating people differently based on where we see them and treat the illness. Third thing, most of you by now are aware of the Choosing Wisely campaign, which is terrific. It's a group of about 60 specialties that have gotten together and have provided a handful, 6, 8, 10 things for physicians to stop doing. Things that we are doing quite frequently, tests we're ordering, things that are often unnecessary and often harmful. And I think as responsible healthcare organizations, we need to begin to put these in front of our providers and have them adhere to them. It's all best advice based on evidence from experts. And as a profession, we don't pay enough attention to that. The next one is I'm asking you to pick a guideline. And I say, pick any guideline. It doesn't really matter. Some of the pushback we get is, there's more than one guideline for hypertension, so I don't know which one to follow, so I'm not going to follow any. And I would say, they're all directionally correct. They're all trying to get us better. In our Measure Up, Pressure Down program, in our literature, we provide 3 or 4 choices from reputable organizations that have been successful at getting the blood pressure control in the range of 80% in their population. So a group is at 65th or 70th percent would do well to choose one of them and follow them. So I would suggest we pick them, we follow it, we monitor its use, and we reward adherence to it. And that might include actually putting that in your comp plan. The degree to which your doctor follows a guideline that improves the care of the patients gets rewarded. The other item that I would talk about is embedded decision support tools we have in our EMRs. When you go down to the exhibit hall, if you haven't already been there, you'll see lots of people who are here who want to provide you with tools to take better care of patients. There are best practice alerts and health maintenance alerts, imaging selection software, order sets. We have to do a better job of putting things in front of the physicians at the point of care so we make it easier for them to do the right thing. I think in this regard, Mark Twain said this best. The last comment I'm going to make is this issue of autonomy. We have physicians who really bristle at the idea of being asked to do cookbook medicine, to follow somebody else's approach. What they'll often say is, I'm really smart, I'm highly trained, I'm licensed, I have a specialty board, And I know about practicing the art of medicine, and I don't want anybody telling me how to do it. So I'm going to just do it the way I want to do it. And I'm going to maintain my autonomy. And my response to that is, the fastest way you're going to lose your autonomy is you keep doing exactly what you said. If we don't have the discipline as a profession to follow the best practice, evidence-based guidelines that our colleagues are telling us about, the result of that will be that our government and our payers will make those decisions for us. And I don't think that's anything that we're looking to have happen. So I'm going to stop there. I hope this provides some thought for you over the next weekend and on after that. And thank you very much.